Okay, why don't we get going? So I am very pleased to introduce Ania Jastreboff, who is an assistant professor of medicine and of pediatrics at Yale University School of Medicine. She did her MD and her dual training in internal medicine and pediatrics at the University of Maryland, and then was seduced by the PhD opportunity that you get in translational research you can get in your endocrine fellowship at Yale. I think that's really been a great addition to have that opportunity as part of the training program, and has attracted a lot of really great people to Yale. And also did both pediatric and adult endocrinology, and developed an interest in neural regulation and the use of functional imaging to assess the neural regulation of food intake, which she was supported by a K-23 and now has a grant from the American Diabetes Association. And her area of clinical interest is obesity medicine, and she's boarded in that and speaks widely in courses on that. So we're really delighted to have her come and tell us about teenage brains on sugar. Thank you.
Thank you so much for that introduction and for having me today. As you know, since I do both pediatric and adult obesity care, I study both. Today I'll show you mostly adolescent work that we did, and feel free to ask any questions as we go along. And this work basically was started because I had this interest in behavior and why people eat what they eat. And so looking at the brain was the natural next step. So here are my disclosures. In terms of what I'll be speaking about, basically the brain, eating behavior, and obesity, I'm going to touch on adolescent brain development, and then I'll tell you about some of our studies, specifically with drinking monosaccharides. Can you guys all hear me okay? Projecting enough? Speak louder. Speak louder. Okay, got it. So as we all know, adolescent obesity has tripled over the last 30 years. A third of children in the United States have either overweight or obesity. And obviously there are many reasons for this, biological and environmental. And what we're interested in is specifically looking at some of the environmental factors and food cues that exist in the environment. So obviously we know that there are many advertisements aimed at children. They're also exposed to highly palatable foods. These foods are inexpensive and they're available 24 hours a day. So this is one of the changes that has occurred. And so what we're interested in is understanding how the brain processes all of this information and how that results in eating behavior. So obviously this is very, very complex. What I'll be focusing on today are central concepts and how the brain processes this information. It's obviously really important to keep in mind that the periphery is critical in terms of the hormones and metabolic factors and how they communicate with the brain. We're going to touch on that very briefly today. And this, for purposes of today's talk, we'll focus in on adolescents specifically and how this might be different in them and how they might actually be more vulnerable to some of these environmental factors. So breaking it down, we have, for example, a desirable food cue that maybe is thought about, seen, or even ingested. This is somehow perceived by the brain. There's a neural response which elicits some sort of eating behavior. Obviously, if you eat the food, you also elicit different responses in terms of hormonal and metabolic factors. And obesity changes those, obviously, and potentially alters the neural response, the eating behavior, and may contribute to weight gain. So this, of course, has therapeutic and public health implications. In terms of therapeutic implications, the work that we do and others may potentially show us some targets in the brain, and I'll kind of show you how that might be. And then also public policy implications specifically also for children in terms of what they're exposed to and what they can consume. So again, this is all in the context of adolescence. So when we think about the regions of the brain that are involved in controlling eating behavior, there's three regions that we talk about. Homeostatic, which is the classic one that we have always studied early on, hedonic and salience, and then cognitive and executive control regions. So obviously homeostatic has been the most well studied, and studies continue in the very important region of the hypothalamus. Early studies obviously showed this to be an important region, with the lateral hypothalamus being called the hunger center, with ablation resulting in an anorectic state, and the ventromedial hypothalamus, the satiety center, basically recognizing fullness, and ablation resulting in obesity. But this is obviously not the only brain region that is important. Hedonic and salient systems have come to really be recognized in terms of their importance over the last 15, 20 years. And basically, they involve various neurotransmitters. Now, what are some of those neurotransmitter pathways that we're talking about? Well, dopaminergic pathways, for one. They're really important in reward, motivation, pleasure, as well as other functions. And the regions of the brain that are important, and I'll kind of be coming back to these regions of the brain, are the striatum, composed of the caudate and the putamen, as well as the nucleus accumbens. Now, the nucleus accumbens is a region of the brain that has been studied extensively in addiction literature, and that's kind of where we got our cues from in terms of obesity medicine and looking at this for mechanisms. So early on, back in the early 2000s, Nora Volkov and Jean-Jacques Wang did a PET study where they looked at dopaminergic D2 receptor availability. And what they found was that in individuals with obesity as compared to lean, the obese individuals had decreased D2 receptor availability. The individuals in their study had very high BMIs, around 50 or 60, but it gave us a clue to start looking there. It's really interesting because when they did studies of this in individuals who were addicted to cocaine, they saw this same, before they did these studies, they saw this same D2 receptor, decreased D2 receptor availability. Now, obviously, these are overlapping regions, and it's almost as if these addictive substances, whether it be alcohol or drugs, such as cocaine, they basically took these food pathways and are using them to get this reward and motivation. So in terms of serotonergic pathways, also very important in mood, memory processing, as well as other things. And why are we talking about this? Well, we're talking about these, and I'm particularly interested in these pathways because of the medications that we use for obesity treatment today. So the anti-obesity medications that we use work on these pathways. So lorcaserin, for example, works on serotonin pathways, the 5-HT2C receptor. Bupropion and phentermine work on dopamine, as well as norepinephrine and phentermine on serotonin as well. And then there's other pathways that are not depicted here. So naltrexone, when it's used in conjunction with bupropion in the medication Contrave, works on opioids, and then topiramate on GABA. So it's really important to keep these in mind. And just to kind of give you a context of where we are with anti-obesity medications, if you look at the ones that work in the brain and then the ones that work in the periphery, and I put liraglutide, or I should put GLP-1 analogs twice, and that's because obviously it's made in the gut, but there's receptors in the brain. But you can see here that these medications are working specifically in the brain, and orlistat is obviously working in the periphery. Okay, so what about cognitive and executive regions of the brain? So obviously we're humans. We make choices in terms of the food we eat. You know, I talk about this in the context of these other pathways as well, because ultimately the goal of some of this research is understanding that although these processes of cognitive and executive control are in place, there's biology at play from homeostatic and hedonic pathways that affect whether and how we're able to have executive and cognitive control over our decisions. So if you look at the prefrontal cortex, obviously it's important in executive function, decision-making, impulse control, and obviously food choices. Now, why is this important in the context of what we're speaking about today in terms of adolescence? Well, adolescence is actually a period of brain development. A lot of the time we just think of early childhood and childhood as the time of brain development, but adolescence is part of that, and actually there's a lot of changes that occur during that time. And so basically, different parts of the brain develop in different ways. So some are simultaneously and some are not. And there's pruning that occurs specifically in various regions of the brain. So here, for example, I'm showing you frontal gray matter, and women or girls are depicted in red and boys are depicted in blue. And you can see that the peak gray matter volume in girls is around age 11 and in boys is around age 13. And what happens is this pruning of various pathways. So depending on what you're exposed to, say you're exposed to highly palatable food or sugar, how could this influence this? Say that there's certain habits that you do. So you keep the connections that are strong and you prune away the ones that are not. So in terms of adolescence, this is important because if we think about the striatum, this reward motivation region or pathways in the brain, and the prefrontal cortex, if they're not developing at the same rate, then there is a time in development where the striatum actually may elicit more of an impact on eating behavior than the prefrontal cortex. And as anyone here who has teenagers may know, they're obviously at increased risk for various risk-taking behaviors, and this may be due to this uneven development of the brain where their prefrontal cortex almost has to catch up to those reward motivation regions of the brain. Okay, so in terms of other changes that occur during adolescence, obviously hormonal and metabolic changes also occur. And we think of things like growth hormone and IGF-1 as well as this simplistic diagram of other changes that occur. But there's also changes in insulin, leptin, and ghrelin. So if we think about those changes, insulin sensitivity decreases by about 50% during puberty. And this does occur in adolescents even if they don't have obesity. Insulin secretion is doubled, and Sonia Caprio, as well as others, have actually shown that this is much, much higher in adolescents with obesity who have, pre-diabetes, and their insulin levels can be 600-700 after stimulation. In terms of leptin, obviously it's proportional to the white adipose tissue, and it looks to play a permissive role in pubertal onset. And in terms of ghrelin, it looks to have a suppressive effect, and children with obesity have lower ghrelin levels. They also appear to have an attenuated decrease in ghrelin response after eating. So in terms of our model of what we're thinking adults and adolescents, so in adolescents what we think is that this occurrence of the PFC having delayed, or not delayed, but physiologically delayed development means that there are increased signals that may take over in terms of decisions for the food that you're eating and continued intake of those foods, and this may be particularly in adolescents with obesity. And then there's obviously the factors that we talked about that may influence that, and all of that results in differences in eating behavior, food intake, and potentially weight gain. So how can we study this in adolescents? So obviously human studies require methods that aren't invasive when we're looking at the brain. So what we are choosing to use is functional magnetic resonance imaging in terms of the brain response, and I'll explain a couple of measures that we do take. In terms of our basic methods, we basically give our adolescents a cue, and the cue can be something like a food story, which elicits thoughts of food, and we did this actually in adults. Showing them pictures of food, so highly palatable, low palatable, and non-food images, and comparing their response. And then ingestion of different things, and in this case we were interested in glucose and fructose. And basically what happens is we expose them to this task during the MRI, and then we sample hormones at various intervals, and we examine what occurs. Now, the measures that we look at include perfusion as well as activation. So perfusion as in cerebral blood flow, so where is there more blood flow to the brain depending on the cue that you're exposed to. And in terms of activation, so there's something called BOLD, which is the blood oxygen level dependent signal. So it basically tells you the amount of oxygenated versus deoxygenated blood. So again, kind of to stress that this doesn't tell us directly about mechanism, but it does tell us where the activity may be occurring in the brain. We obviously can't take their brains out and look at what happens, but this gives us ideas of where activity is occurring. So in terms of how we depict this, so this is obviously a brain slice, and increased perfusion or activity in my slides will be depicted as yellow, orange, and red, and decreased perfusion activity will be depicted as purple and blue. Now, regions of the brain that are important, I showed you some of them in the schematic diagram, but here I'll show you where you'll see them on these axial images. So the hypothalamus, important obviously in hunger and satiety, as we talked about. It's difficult to see on fMRI because it's such a small region, but with better resolution, with the machines that we have now compared to the machines we had 15, 20 years ago, it is possible to look. Striatal, so reward motivation regions, and here you see the putamen, and here is the caudate outlined in green. Limbic and emotion memory regions of the brain, so here's the amygdala, and the thalamus is actually right here. And then cortical regions, which is the gray matter. It's a very large region of the brain. So the prefrontal cortex, the anterior cingulate, important in impulse control, and the insula, which is important in interoception and taste perception. So first I'll just show you briefly neural responses to food cues in these adolescents with obesity, and then I'll move on to talk about the glucose and fructose studies. We looked at 40 adolescents, 15 were lean and 25 had obesity. Their mean age was 15 and they ranged from 12 to 19. Here what you'll be seeing is the difference map between high calorie food versus non-food pictures. So where the difference between how they perceived these high calorie food pictures or highly palatable food pictures, such as this delicious lava cake. And what you'll be looking at is what is more in the obese as compared to the lean. So it's the average of the group, not individual brain slices from individual participants. And again, the activation, the BOLD signal will be depicted in yellow and orange. And so what we found was that obese or adolescents with obesity as compared to lean adolescents had increased responses in many regions, so including the caudate, so important in reward and motivation, and the putamen, and then also the hypothalamus, the amygdala, the thalamus, and then the insula, this brain region important, and taste perception. So clearly there were differences that we saw in terms of pictures, but of course we were interested in how does food ingestion actually affect these brain responses. So we decided to look at sugar for many reasons. One of them being, I'm sure you've seen these graphs before, is that sugar consumption and obesity have risen together, and some people believe that there is a component of this excess sugar consumption that contributes to obesity. Bless you. So sugar-sweetened beverages are 35% of all the sugars consumed, and I put this 1970s ad on here. It's, right now we think it's hilarious. It's like tobacco ads, but we did have these for sugar. And here is this lovely woman, and she has a diet hint, and her diet hint is have a soft drink before your main meal. And sugar might be the willpower you need to curb your appetite. So this is the 1970s, and there's this lovely description here of how it has low calories, but will immediately give you energy faster than anything else, and that this is what you should do in order to be able to keep your weight down. So if you look at sweetener and caloric sweeteners over time, basically the highest or the peak was in 2000. And it's interesting, some people definitely focus in on this refined sugar versus corn sweeteners. And I definitely am interested in high fructose corn syrup, and we are starting to do that in the next study that I'm doing. But the data we have right now is for glucose and fructose. But obviously they're usually consumed together in combination. Now adolescents are the highest consumers of added sugars. So more than 20% of adolescents' total caloric intake actually comes from added sugar. And nearly half of those added sugar calories are from sugar-sweetened beverages. So if you think about it, really, this is impacting them the most, more than anybody else in the United States, potentially. And then now couple that with the fact that their brain is still developing and potentially at higher risk for influence, this really adds to the potential problem and the fact that we should potentially do something about it. So in terms of neural responses to drinking glucose and fructose in adolescents with obesity, this is what we did in terms of the study procedure. So they came in and they had a fasting plasma sample to kind of see where they were at baseline. And then we did a baseline MRI scan, and then on different days, in random order, they either got glucose or fructose, 75 grams. Then we put them back in the scanner, had them lie down again, repositioned them, and did the scan again. A couple of things with this as you think about the study. One is that we used the same amount of glucose and fructose for both adolescents with obesity and adolescents who were lean. And obviously this was a big discussion point because should we base it on body surface area, body mass index, what should we base it on? And we chose in the end to give them the same cue, and part of the reason why is because if you consume a specific amount in real life, is that going to affect you differently whether you have obesity or lean? But it's an important consideration because potentially it's being perceived differently. And then we measured various insulin, glucose, and other factors throughout at 10-minute intervals over the 60 minutes that they were in the scanner. The other thing to consider too is that adolescents, and especially adolescents with obesity, have a hard time being in the scanner. So there's various things that we do. We bring them in ahead of time and kind of get them used to the scanner as they're lying down. Adolescents with obesity, we have to have a head coil on them to make sure that they're not moving, lean as well. And it feels more constricted because their head size is often larger. And so there's definitely some things to consider there. We do have motion detectors, but if there's too much motion, the data has to be discarded, which of course is problematic because these scans are very, very expensive. And we also have eye motion detectors to make sure they're not falling asleep, which is also important. Obviously, our adults actually seem to have a problem with that, and that's because lack of sleep, and adolescents too, but adults too. So we do try and make sure that only the best scans are included, and we have all these things that we do to preemptively try and get that. So in terms of demographics, they were on average 15 years old in both groups. There were 14 in the lean group and 24 in the group with obesity. Part of the reason we wanted more in the group with obesity, one is that was obviously our main focus, but two is initially we wanted to see if we could parse out the differences between insulin resistant and insulin sensitive adolescents. We did look at some of that data, but because the samples are small, so as we were discussing this actually last night, we'd like to have 20 in each group. But as funding runs out in whatever funding mechanism you have, sometimes this is what you can do. And basically the criteria have changed over time in terms of stringentness in that. So in terms of race, they were pretty well matched. We really focused on that. In terms of sex, there were more women or girls in the obese group. It wasn't statistically significant, but there were more girls with obesity who participated In terms of body mass index, our lean had an average of 21 and obese 34, and obviously by BMI Z-score, because that's what we use in pediatrics, the group with obesity were all above the 95th percentile. And then percent body fat measured by Tanita scale was obviously higher in our adolescents with obesity at just over 40% body fat. Oh, and I should mention one other thing. The studies that were done with PET in individuals with BMIs of 50, 60, we can't do with the MRI scanner that we have, and most people have. And that's because it's a tube, so you obviously, in PET, it's open, so you can actually have larger individuals. And the other thing is there's a limit on the table, so we can't go over a certain limit in terms of weight. Now, Yale is acquiring a larger MRI, and that's because so many of us have asked for that so that we can actually have potentially larger group differences. And we also think that this population that has severe obesity, I don't like to use the word morbid, but severe obesity with a body mass index over 40 and over 50 really are understudied. So in terms of fasting metabolic profile, so in our lean and obese groups, there was a slight difference in terms of fasting glucose, with the obese having average of 91. Fasting insulin was obviously higher in the obese adolescents, or the adolescents with obesity. And then we looked at 2 measures of insulin resistance. They all had OGTTs. So by WBISI, there was a difference. Obviously, our sample was small, so one might argue we should not have calculated HOMA. And there was no difference in that. And then leptin was obviously higher in our adolescents with obesity. So in terms of the response to the glucose drink, well, they were in the MRI. The lean are depicted in red, and the obese adolescents are depicted in blue. And as would be expected, their glucose levels were actually similar, but their insulin levels were different. So again, as we would think, the adolescents with obesity had higher insulin levels as compared to the lean. In terms of fructose drink, again, as would be expected, not much change in glucose. Again, this was interesting. There was actually a difference in terms of insulin response with the obese adolescents, or the adolescents with obesity having higher insulin levels. So again, what I'm going to show you here are average difference maps. So this is the difference between baseline. So when we do the baseline scan, then they come out of the scanner and they drink the glucose or the fructose. And again, and this time what I'll show you is lean and then obese. So in terms of the lean adolescents, we saw increased now cerebral blood flow because it's in response to the drink in the prefrontal cortex. As well as somewhat in the caudate. And again, we choose specific slices, and depending on which slice you look at, you'll see different amounts of perfusion differences. In the rather than increased perfusion in the prefrontal cortex, we saw decreased perfusion in the prefrontal cortex, as well as the anterior cingulate, important in impulse control. And then we also saw increases in cerebral blood flow in the thalamus and the caudate, one of those reward motivation regions of the brain, and then also the hypothalamus. In terms of response to fructose ingestion, what we found was in response to fructose, again, a decrease in cerebral blood flow in the adolescents with obesity in the prefrontal cortex, as was seen with the glucose. Also, the nucleus accumbens, that region of the brain really important in addiction literature that has been described, demonstrated increased activation in the adolescents with obesity. And so kind of to summarize this, adolescents with obesity, this is the same image but now side by side, a little larger so you can see it, had decreased perfusion in decision-making regions of the brain and increased perfusion in reward motivation regions of the brain. So decreased in the PFC, HCC, and then increased in the caudate. So as was pointed out, this is an effect of leptin on neural response. So we decided to look at one factor in terms of leptin, and we knew that leptin was higher in the adolescents with obesity. And this is just a graphical depiction of that, with the obese adolescents having an average leptin of 37 versus 8 in the lean. And what we did was whole brain correlations with leptin. So in this technique, we don't pick a specific area. We basically look at the whole brain. So it's not influenced by what we may think is occurring. And what we found was that whole brain correlations with leptin in adolescents with obesity, there was, so this is endogenous leptin, we didn't give it to them, correlated with decreased perfusion in the prefrontal cortex. And so what we thought is that perhaps this dysfunctional or leptin signaling may contribute to lower PFC or prefrontal cortical response in adolescents with obesity. And this goes in line with a study that had been done 7 years prior to this by Jastreboff, where she actually gave leptin to leptin deficient individuals and saw a change in the prefrontal cortical activation. So this is just another way of potentially looking at it, but it's definitely interesting. So now the question is, how are these decision-making, reward motivation, and homeostatic brain regions working together in response to glucose ingestion? And again, in terms of the methods that we have to use, we're using fMRI, and so there's different analysis techniques that can be used. And functional connectivity analysis is one of them. Now, any of you who may be familiar with fMRI know that there's different ways to do this, and the initial way that was developed was to use a seed. So basically, you pick a brain region and you seed it, and you look and see what other brain regions are activated at the same time or simultaneously. So it's not telling you about a temporal relationship. It's not telling you, oh, the prefrontal cortex activates, and then the striatum activates, and then the hypothalamus. It doesn't tell you that. What it tells you is what regions of the brain are activated simultaneously. And so in terms of the seed region, you can use either a functional or anatomical seed region. So anatomical just means that you pick a brain region and you know where it is anatomically on average in most people. Or you can use functional, meaning what did you find on your studies that functionally responded to whatever task you were giving them, in this case glucose and fructose, and then use that. And we used functional seed in this study. So the seeds that we used were the hypothalamus, and then the prefrontal cortex, specifically Brodmann area 10. And the reason we chose Brodmann area 10 is because this was an overlapping region. Meaning in lean adolescents, we had seen this increased perfusion, and in adolescents with obesity, we saw this decreased perfusion. And it's an area of the brain that is important when you're doing, quote, simultaneous tasks, which we know we really can't do. But let's say you're trying to keep a task in your mind while you're doing something else. So I'm looking at the clock, and I'm speaking with all of you at the same time. So that's what this Brodmann area potentially does. So what I'm going to show you here is on this side the lean, and on this side the adolescents with obesity in response to glucose drink, and this is the connectivity with the seed region of the hypothalamus. So at baseline, so this is before any drink, before any stimulus, before anything, they're just in the scanner, awake and getting scanned. The lean adolescents had no increased connectivity with the hypothalamus seed region. They were just chilling. The adolescents with obesity, on the other hand, demonstrated increased connectivity with regions that we talked about. So the caudate especially, it's basically like the entire caudate shown here, and other regions as well, but these cortical limbic regions that are really important, and specifically the caudate in terms of reward motivation. So what happened after we gave them the sugar? So what happened was the connectivity with the hypothalamus in the lean adolescents, there was increased connectivity with the putamen, as is shown here, and the thalamus, which is an important relay center of the brain. We think that it helps integrate signals from various regions of the brain. Whereas in adolescents with obesity, they had this continued increased connectivity with the caudate and the putamen, these reward motivation regions of the brain, as well as the thalamus. So then what we did is we took the difference map. So we basically looked at how is before or how is after different than before, a subtraction map. So we decided to do this to look at the response to the actual glucose drink. And what we found was that in lean adolescents, they had a difference in the after versus before in the thalamus, this relay center of the brain, and the insula, this region of the brain that's important for interoception and taste perception, whereas the adolescents with obesity had no difference in response. And so the idea being that in some way they have this increased connectivity or increased activation in their brain even before they ingest anything. And then when they ingest the glucose, there isn't a difference. So are they perceiving it differently or not perceiving it? Which is, one of the reasons we had raised this question of the amount of glucose ingested. But it doesn't change the fact that at baseline they had this increased connectivity already. Now we also looked at this Brodmann area 10, and what I'm showing you here is the difference map. To look at how this specific region had connectivity with other regions of the brain. And so what we saw is that in lean individuals, Brodmann area 10 had positive connectivity with various other regions of the prefrontal cortex, including the anterior cingulate, and it had strengthened negative connectivity with the hypothalamus. In adolescents with obesity, there was no increased positive or negative connectivity with Brodmann area 10 and other regions. So basically, no change. So how do we put all of this together? So in terms of how this may all be perceived in lean as compared to adolescents with obesity. So in lean, what we think is occurring is that they ingest glucose, and there is increased perfusion in the prefrontal cortex, which is what we saw. Now, this potentially exerts inhibitory signals to the striatum, this reward motivation region of the brain, as well as the hypothalamus. And again, this is a model. And then the hypothalamus then isn't saying drink more glucose. Then in the adolescents with obesity, they drink the glucose and they demonstrate decreased perfusion or in the prefrontal cortex, and thus they might have blunted inhibitory signals to the striatum as well as the hypothalamus. And therefore their striatum, this reward motivation region of the brain, may remain more activated. So what are we concluding from these studies? So these findings suggest that reward motivation and emotion regulation regions of the brain may be dysregulated in adolescents with obesity in response to glucose and fructose ingestion. Adolescents with obesity may have decreased ability to make decisions. So again, they have decreased perfusion in their prefrontal cortex, and potentially this may be affecting their decision making. And they have increased motivation for glucose and fructose consumption. And this is especially evident with increased activation in reward regions with fructose ingestion, as I mentioned, the nucleus accumbens. In terms of the role that leptin may be playing, so leptin may play a role in decreased perfusion. We don't obviously know that, but there's now a couple of studies that may be demonstrating that, as I mentioned. And this dysregulation may result in increased motivation to consume glucose and fructose and decreased control over consumption of these simple sugars, thereby perpetuating obesity. Now, what do we think overall? Well, potentially that adolescents with obesity may be particularly vulnerable during this period of development, and they may have this diminished executive control over reward motivation and homeostatic responses to food cues and eating or consuming highly rewarding foods. Obviously, this is a model and it needs to be tested further, but potentially we think that this is what may be occurring. Now, as any good physician scientist, there's more questions than answers, and potentially lots for everyone to do. So if there's budding scientists in this room, these are some of the questions you might choose to answer. And the thing I would say is that better technologies are emerging, so you may be able to do this in some rigorous ways. So in terms of cause and effect, are these differences in the brain response due to obesity, or is it that they themselves contribute to the development of obesity? So this is a question that I always get: is it the chicken or the egg? Basically, did these changes already happen and then cause people to eat more, consume more, or did they result because of obesity? So in terms of timing, when do they occur? And there's some interesting studies that are ongoing now by some of my colleagues in terms of long-term childhood or even in utero. So for example, if your mother has obesity or gestational diabetes, is that then going to affect you differently, and are your brain responses different? And it's really interesting, and those studies are ongoing now in a cohort, and so we'll see how that turns out in the long run. In terms of impact, what are the behavioral implications of the observed neural responses? So it's all well and good. I'm showing you, things lighting up and things going down, but what does it really mean in terms of behavior? Does it really translate to any behavior at all and changes in glucose and food ingestion? What we're doing now is basically giving them tasks after we do these MRIs. And again, it's correlation, so we can look at do the brain responses in any way relate to what they're consuming and how they're responding. But again, that's the starting way to do this. The other thing to consider with that is it is in an experimental setting. It's not in real life. So how can we translate some of this into real life? In terms of eating responses as well as then therapeutic implications. So in terms of reversibility, how reversible are these changes if they do in fact impact eating behavior? So can these differences in brain response be reversed with weight loss? And there are studies looking at that. There's a few studies that looked at this in bariatric surgery patients as well. And if so, in terms of weight loss, what treatments would actually enable this and changing these potential detrimental changes in the brain, and are they sustainable? So one of the things that we often talk about is lifestyle interventions are critical, but often very difficult to sustain. And so using things like medications, anti-obesity medications that potentially change physiology and potentially, as I showed you, work in these regions of the brain, are they more sustainable because they actually change physiology? And with that, I will just thank everyone, especially my mentors, Bob Sherwin, who recently retired from Yale. And we're very, very sad about that for many, many reasons. Rajita Sinha, who's the neurobiologist who really I started working with in terms of learning this fMRI and neurobiology several years ago. Sonia Caprio, whose grant supported this project specifically. And then all of the other funding sources that we have, and now ongoing work with the ADA funding. So I'd love to take your questions and discuss what we talked about.
You had a chance to look at what happens before and after bariatric surgery?
So I have not. There are other groups that have. It's a great question. One of the studies was reported within a review article. So I don't know if they had enough patients to actually look at that. One was PET and one was fMRI, and one showed that the changes reverted and the other one did not. So there's not a great answer, but I think there are other people looking at that. It was one of the initial things I had thought about looking at before I got diverted to some of these other things, but it's a great question.
Have you looked at continuous glucose monitoring in both groups to see maybe if obesity gets higher? I was struck by the fact that when you started at baseline, dopamine 2 receptors would decrease when you did the scan.
Yeah, Norabop.
So,
yep.
but what you see in my not suggest that they already occupy.
Yes, yeah.
Whatever is occupying.
Whatever's occupying it. So it's interesting, in terms of your question about CGM, we're doing it in the ADA study. Yeah, so awesome. So we're doing CGM before and after, we're actually doing an intervention, we're gonna look at how the average, the MAGE and the average of the blood sugars and the variability relates to neural responses. So I think it's a great question. We're doing it in both individuals who are lean and individuals who have obesity. We did want to do this study in adolescents. The problem was we had some IRB issues, so we ended up doing young adults up to age 29, not because of the CGM, but some other things in the study. But hopefully we'll have those results in a couple of years. So great question. Thank you for that.
So yeah, when you ingest glucose, obviously, as you show, insulin goes up. So any approach to dissociate the effects of glucose versus insulin, and you mentioned that you did do plans.
Yeah. So in my K23, which we're analyzing now, we did euglycemic hyperinsulinemic clamps, and what we did is we basically kept the blood sugar at 90, and we obviously raised insulin levels. And that was exactly to answer that question. So we'll see what the results are of that. But that's a great question too. Thank you for suggesting all these studies. Yes.
How about longitudinal studies in high-risk kids or adolescents?
Mm-hmm. Yes, absolutely. So a couple of people. One, Dana Small, who we talked about last night, and who you saw last night on the train. She did some work, or is doing some work with children of mothers with obesity, or I think it was one parent or two parents with obesity. So we'll see how that turns out. And then Katie Page, who was also trained by Bob Sherwin at Yale, she went to California, and she has a cohort of children who are eventually going to be adults, but children who are of mothers who have gestational diabetes. And she is following that cohort. It's a cohort from Kaiser Permanente. She's following that cohort longitudinally over time, including with neuroimaging. So I think we'll have some great results from that as well. And it's wonderful that those types of studies are funded, because basically, you just have to keep on getting the R1 renewals to do that. So that's a great question.
That's a great talk.
Thank you.
I think that you get to make a choice, I guess, to put an MRI or a PET.
Yeah.
So what's your guess about how low they would correlate in this kind of study?
Yeah, no, it's a good question, and I'm just starting to do a little bit of PET imaging. Obviously in adults, we can't do it in children because of the radioactivity. And it can tell us a little bit more about mechanism. So we do have a great PET center. They develop all these nice radioligands for us. So I do agree that may tell us a more. I think ultimately that there's going to be new technologies, and they're already evolving. Like with fMRI, there's a lot more analysis techniques that are being used in other fields that obesity medicine is not adopted yet and does not understand. And part of that is because these are so complex, and it's so difficult to understand that. But I do think that we need other techniques that give us a little bit more insight into mechanism, rather than these types of studies, which are more hypothesis generating and important, but don't answer specific mechanistic questions.
You just think that glucose then, as opposed to other guys that just glucose up to
Right, like FDG. Yeah, and some of those have been done. Again, initially I wanted to study kids. I still want to study kids, but and I want to study adults, and so kind of had to make a choice. But I do agree. There's obviously limitations. So, yeah.
So talking about MR and
Mm-hmm.
I don't know all these
Yes.
amazing
Yes.
studies looking at really getting into the metabolism. So glucokinase is really, really important. It's interesting when you look at fructose and glucose,
Yeah.
and they have differential effects.
Yes.
So I just wondered, is the technology sufficiently good to allow you to understand kinase with that?
Right. So I think for this, no, obviously, but I do think, and there's other things also that I didn't mention and talk about. For example, some of the studies that Dana Small is doing that is considering taste perception. So she has a gustatometer in the MRI, so it's basically a mechanism of delivering milkshake or other substance, you pretty much do anything, where they will take a swallow, and it's basically moment to moment. What we do is we give it to them, and then we put it in, and we look at the response over time. So there's other things that we have to consider in that, not just, this type of response, but in terms of taste perception and other things. So I think in terms of parsing that out or parsing out these other elements, this isn't like the perfect technique, obviously, but it just gives us some clue. Yeah, and then I'll go to the back. Yeah.
Have you thought about seeing what happens with oxytocin?
Yeah.
PDB.
Oh, that's really interesting. And there are some studies looking at this for anti-obesity treatment, especially in kids who have had like hypothalamic obesity. There's also some studies with hypothalamic obesity using GLP-1 to help with that. So it's interesting. I have not. I don't know if others have at this point, but it's definitely an interesting compound to consider and look at. Yeah. So we'll go to the back and then I'll come back.
So mentioning the egg question.
Yes.
Is there a prevailing hypothesis of what comes first? Is it the obesity that causes the changes or changes that cause the obesity?
Yeah, so that's a good question. There's research on hypothalamic inflammation that happens, and you know more about that than I would, obviously, but that changes that occur with eating, say, a high-fatty food meal. So I don't think that there's a definitive answer, but there's the potential of eating these types of foods may potentially change inflammation in the hypothalamus and other regions of the brain. Yes.
Regarding the IRB process,
Yes.
doing all of this research, can you give us the complexity of when you read the IRB
Yeah.
and the changes that they will
Yeah.
say, parent should be involved, no, this is a liberated adolescent, we don't
Yeah.
do this.
Yeah, so, and that's a great question too, and that's why the plant studies that I did were in adults. We wanted to do lean, and so yeah. But, so our IRB, like others, it's really rigorous, and that's good, right? We don't want to harm anybody, obviously, and like for the CGM study, we have to take the CGM off before they go in there. There's no metal. It's really hard because with kids, if you have braces, you have artifacts, so you're excluding people. But, it's a rigorous process. They go through everything. They assess risk. And for this, they're drinking sugar, so the major risk is if they get claustrophobic or nauseated or something like that, or they just feel uncomfortable in the scanner. Those are and then phlebotomy, right? They get an IV, and then the nurse comes in and draws the blood every 10 minutes. And then the other thing to keep in context is that they look at, who is doing what in every step of the way to make sure that they're highly trained. So for these studies, we need myself or a physician equivalent, a research assistant, a nurse who draws the blood, a lab person, an MRI tech, and a research assistant. So it's like a village to do one person, and the cost is obviously substantial. But the IRB looks at all of that, and then we kind of go back and forth. And,
You pay the participants.
Yes, we do. And part of that is they don't have any gain from this. Like, what are they? There's no benefit to them. So we do pay them for both types of studies, depending on how many. And that is also significant as well. And then the cost of 1 hour, and it's not 1 hour of scanner, is over $500, but it's not 1 hour because you have to have a time where they go in there, they get positioned, they drink the sugar, and then you scan them for an hour. And then what if they need a bathroom break? Then we have to reposition, and do you know what I mean? Which in this didn't happen as often because it's only an hour, but in our clam studies it did because they're getting fluids, and they have a saline day where they get fluids, and we give them different amounts of glucose. So there's definitely things to consider.
Do you exclude kids taking SSRIs?
Do I? Yes, I do. So I treat both adults with obesity and less so, but I also treat adolescents.
But I mean, the trials, they were also.
Then none of them were on medication. So they were not allowed to be on any, metformin, any glucose lowering medication. They were not allowed to be, SSRIs, nothing like that, because they could obviously impact brain function. So good question with that. In terms of clinical work, I do use the anti-obesity medications off-label in adolescents. Obviously I do it extremely carefully. In my adults with obesity, I use multiple agents because in order to help someone lose 50, 60 pounds with medications, not with surgery, that's what you need to do. And some of them do get there. In terms of adolescents, I generally stick with 1 or 2. but then they grow up to be adults very quickly, and then we add on. So, but potentially it's because we don't know what the long-term effects are. So it's kind of, do you have them grow up in this state that is, excess adiposity with all the detrimental effects long-term, or do you try and treat the obesity with the potential of side effects from all these medications long-term?
Any fundamental difference in how you use drugs in adolescents versus adults?
Yes. So one is that I definitely speak with the parents and try and assess motivation. And I'm very careful with my prescribing of phentermine, even though phentermine is safer in children because they don't have the cardiac, effects and things like that. But or complications, I should say. But it isn't, potentially addictive. They can sell it to their friends. They can give it to their friends. So I am much more careful. I have the adolescents and the parents sign. The parents sign consent. The adolescents sign assent, and then they come back regularly. So initially it's once a month, and then it's once every 3 months when they're stable. And it's, and the problem is we don't know what works for each person. So if you try an agent, it doesn't happen to work for that person, and then they leave, the adolescents are less likely to be like, oh, I'll come back for another one, in terms of motivation. The other thing that I really assess in both adults and adolescents is their adolescents obviously eat a diet like this that includes a lot of fast food and sugar. And if your diet consists of, say, gummy bears and soda, it's much harder for these medications to work, although they can help at least potentially decrease the amount. But I do that. I'm a lot more conservative with my adolescent patients, although it's interesting because nationally, when I give these talks, and specific to medications, not this, but specific to the anti-obesity meds, and also in terms of papers and stuff, what I prescribe is actually probably more than the general population. I just don't recommend that every pediatrician go out and start prescribing these agents now until we have some long-term data to see, is it safe in puberty? How does it affect bones? How does it affect brain development? How does it affect all these other things? But SSRIs and other things are used in adolescents to treat depression. So it's not like we're not using these agents, and most of the things that we use in pediatrics a lot of the time are off-label, because we don't have enough studies. And so it's a bias, I think, against obesity to say we can't treat adolescents with these. I'm not saying a young child, but adolescents, because especially your BMI is 50, 60, when you're 14 or 16 years old, that's really bad, obviously, for long-term effects. And in terms of adults, it's a process. So it's not like they go on all the meds. You sequentially start each one. You see how they respond. If they gain or lose 5%, you base it on that. And some people have a lot more response and some people have less, and you sequentially add on. So they may get to 4 or 5 agents, but again, that's how you get to 50, 60 pounds weight loss. So pretty expensive for that. One more, and then we're, yeah.
These patients that haven't grown medication, have you tried to do it for, I don't know if you've done it, do the MRIs before and after the treatment and see if there's a different pattern in the activation of the brain?
For medications, yeah, we're doing that right now. So stay tuned, in a few years we'll have some answers for you. Yes? Yeah, so I haven't done neuroimaging studies with those children, but in general, if I see them, there are studies that have been done looking at metformin and various agents like that, and starting them simultaneously. So to try and prevent metabolic syndrome and weight gain, and obviously, as with everything that we use for obesity treatment as well as other diseases, in some patients it works, in some patients it doesn't, but I immediately kind of go in for that. In terms of other medication choices for those adolescents and adults, I then move to GLP-1. And the reason why is those are the least two to affect mood. All the other medications work in the brain, for sure, and we know that they can affect mood. And liraglutide, they looked at it in terms of mood effects and things like that, but those are the two that I go to for adolescents that have those types of medications.
So, thank you very much.
Sure.